Hello doctors. Today we are here with another topic of pediatric surgery, that is disorders of the intestinal rotation and fixation. This is an important topic for both theory and practical exam for both NEET UG and PG students. So starting with the malrotation. What is malrotation? All abnormalities of the intestinal position are known as malrotation. An improper placement of the intestinal loop causes malrotation. First malrotation was reported by a doctor named as Moll in 1898, and very famous, as you know, the lad, Dr. Ladd, in 1932 have performed 21 and reported 21 cases of malrotation. Therefore, the operation that we do most commonly in malrotation is Ladd's procedure. Now we have to know the embryology. In concise way, the embryology, we have three stages: stage 1, stage 2 and stage 3. In stage 1, in 4 to 10 weeks, there is physiological umbilical hernia. As I have told in my earlier video also, in 4th week, the abdominal wall development starts. And approximately in 6th week of gestation, there is rapid intestinal growth, because of which there is physiological umbilical hernia. And by the 10th week, the midgut returns into the abdomen again. And if it doesn't return, it causes omphalocele. So this is stage 2. By 10 to 12 week of gestation, there is the midgut returns to the abdomen again. Then we have the stage 3. Stage 3 is the fusion of the mesentery plus fixation of ascending and the descending colon. As you know, ascending and descending colon is fixed, and transverse colon is mobile, and sigmoid colon is mobile. So the fusion of mesentery and fixation of ascending and descending colon is by stage 3. Now, as I have told in stage 2 that there is return of the midgut into the abdominal cavity again. You have to remember that the small bowel is returned. First segment which returns into the abdomen cavity is the small bowel, and at last the cecum and the right colon returns to the abdominal cavity. And in this cases of malrotation, the neonate is associated, 30 to 60% of neonate are associated with heterotaxia, or rarely situs inversus, means heart is present in the left side. The neonate may present with gastrochiasis or congenital diaphragmatic hernia, omphalocele, duodenal atresia, duodenal web, or mesenteric cyst. Just remember, 30 to 60% chances are there to get associated with these conditions. Now there are many types of rotation. We have non-rotation, incomplete rotation, and reverse rotation. I have made a simple table for you so that it will be easier to remember what are the different varieties. First is the non-rotation. What is non-rotation? Non-rotation is when herniation followed by arrest after first rotation. The first rotation have occurred normally, but after that the rotation didn't occur. Rotation have stopped in the gestational age. So in this case, how will you identify it is a non-rotation? Non-rotation, we will find small intestine over the right side and large intestine over the left side. Just remember, L for large intestine, L for left side. Remember like this. Okay? Then small intestine over right side and large intestine over left side. This is non-rotation. Number 1, remember. Number 2 is reverse rotation. What is reverse rotation? There is herniation. Herniation have occurred. Plus there is normal first rotation. But after that, there is reverse rotation. The rotation is reverse. And in this case, the transverse colon is overlapped by superior mesenteric artery and small intestine. This is the transverse colon, and so this is ascending colon, transverse colon, and descending colon. This transverse colon, above this have this red color is the superior mesenteric artery, and the small bowel crosses over the transverse colon, and this is seen in the reverse rotation. Fine. This is reverse rotation. First was the non-rotation. Reverse rotation done. Then we have the mixed rotation. In mixed rotation, there is normal first rotation, normal second rotation, but there is an absent third rotation. This is known as mixed rotation. In this case, we might find in neonate that there is subpyloric cecum. Pylorus of the stomach is present. Behind the pylorus there is cecum held by the Ladd's band. Ladd's band, which compresses the small intestine. So this is mixed rotation. And number fourth and final is the incomplete rotation. What is incomplete rotation? Incomplete rotation means incomplete third rotation. Means there is normal first rotation, normal second rotation is present, but there is third rotation was occurring, but it has not completed fully. In this case, we will find subhepatic cecum. This is the liver in pink color, and behind this is the cecum. Subhepatic cecum is seen. So there are four types of malrotation majorly. Number one is non-rotation, where the first rotation is normal, but after that there is no rotation. This is non-rotation. Second is reverse rotation. First rotation is normal, but after that there is reverse rotation than the normal. This is reverse rotation. Then we have mixed rotation. In mixed rotation, we have first and second rotation normal, but absent third rotation. And in incomplete rotation, we have first and second rotation normal, but we have incomplete third rotation. Remember this four, and I have made this table precise for you so that it will be easier for you to remember. Now there is incidence. 55% of cases of malrotation are reported by first week of life. Generally, the neonate presents with a bilious vomiting in first week of life. Then 80% of cases are reported within first month of life after birth, and 0.2% of cases remain undetected, which are not detected even during the neonate period. Now clinical features. Now clinical features may be present in an neonatal period or in an older infant. If it is a neonatal period, I have already told the neonate will present with bilious vomiting, and midgut volvulus may also be present. And midgut volvulus may be associated with progressive bleeding. Either it may be upper GI bleeding or it may be a perrectal bleeding may be present. But in older infant, there is cyclical pain in the abdomen. There is fullness of abdomen is present even after eating a small amount of meal. The patient may be full, that is early satiety may be present, or chronic abdominal pain, malnutrition, failure to thrive, and pain after eating. So these are the features that are seen in older infants. Now we have two type of presentation may be there. One is acute presentation, or it may be a chronic presentation. If it is an acute presentation, means there will be bilious vomiting, rectal bleeding, upper GI bleeding, crampy abdominal pain will be there, and distension of abdomen will be present. But in cases of chronic midgut volvulus, there will be chronic symptoms like for long period of time there is a vomiting, there is intermittent colic pain. The patient might present with diarrhea, hematemesis, constipation, protein calorie malnutrition, bilious vomiting, and bilious vomiting in conjugation with abdominal pain, and this is a surgical concern until and unless proven otherwise. Now, apart from acute midgut volvulus and chronic midgut volvulus, the patient also can present with acute duodenal obstruction. And acute duodenal obstruction due to congenital Ladd's band across the third portion of the duodenum is compressed because of the Ladd's band. And while we do X-ray, we will find double bubble sign, and symptoms will be the child will present with bilious vomiting. This is a X-ray and this is the double bubble sign. Okay, here we can see first bubble and we have the second bubble. You also remember that in CHPS, we have single bubble sign, congenital hypertrophic pyloric stenosis. We have a single bubble sign, which will be covered in my next chapter on pediatric surgery, under pediatric surgery. And we have triple bubble sign. We have triple bubble sign in jejunal atresia. Jejunal atresia. We have triple bubble sign, and double bubble sign is seen in duodenal atresia or acute duodenal obstruction. And the patient may present with chronic duodenal obstruction, in which the chronic features will be present as I have told earlier. Then asymptomatic malrotation may also be present, like when the kid will be 10 years old or 11 years old, then the patient will present with symptoms. Initially the symptoms are not present, therefore asymptomatic malrotation. Number fourth is the reverse rotation with chronic obstruction may be present, which is also seen in older age group in 20s and 40s, and volvulus of the cecum may be present due to inadequate fixation of the cecum, and this is seen in more than 60 years. And remember this, in cecum volvulus, the cecum is rotated clockwise, and in sigmoid volvulus, it is anti-clockwise. Fine. Now investigation to confirm your diagnosis. First is the radiological investigation that we do is plain X-ray. In plain X-ray, we can see double bubble sign, which I have already shown you in the X-ray. Then gasless abdomen may be present. Because of obstruction, there is no gas. The normal gas which should be seen in large bowel, there is no gas. So gasless abdomen will be present, and absence of normal colonic gas pattern is seen. Now we will do ultrasound and CT scan after X-ray. In ultrasound and CT scan, we mainly see the whirlpool flow pattern. What is this? This is twisting of mesentery and superior mesenteric vein around the superior mesenteric artery. Because of this twisting, there is whirlpool flow chart. Here we can see this is the whirlpool. This is known as whirlpool. Fine. And if we can see whirlpool sign in ultrasound or CT scan, means there is an volvulus, and immediately patient should be shifted to OT and surgical exploration should be done. Fine. We can see whirlpool sign in ultrasound and CT scan. Now we can also do upper GI contrast study. Either we will do barium swallow or barium follow through meal can be done, and in this case abnormal duodenal configuration is seen, that is also known as Z sign. What is Z sign? Z sign is a sharply angulated. Z sign is sharply angulated to and fro course forming a Z shape rather than the normal smooth gentle curve of the ligament of Treves. Here we can see the Z sign. There is a sharp angulation present here. This is Z sign, which is seen in cases of volvulus or atresia of the duodenum. This is known as Z sign. Another sign that can be seen in upper GI contrast study is the corkscrew appearance of the volvulus. Here you can see this is a corkscrew appearance. This is a corkscrew appearance. And proximal to the corkscrew, we will have the dilated bowel loop. This is the dilated bowel loop, and distal to the corkscrew there will be no air or gasless abdomen may be present. Even in the whirlpool sign also, proximal to the whirlpool sign there is dilated bowel loop, and distal to the whirlpool sign we have the gasless or constriction may be present. Gas is not present in the bowel loop. So how will we treat this condition of malrotation of these malrotation of the gut? First is the patient or neonate may be dehydrated or dyselectrolemia may be present. So we have to correct the dehydration and dyselectrolemia. Then we will insert the Ryle's tube is inserted, and parenteral IV antibiotics are given, as patient might progress to sepsis if there is a prolonged period of acute obstruction. Then the operation that we do is known as, very important, remember the name, is the Ladd's procedure. We do Ladd's procedure. Like generally there is a Ladd's band present. There is a band present which causes the intestine not to rotate properly. Malrotation, therefore, because of Ladd's band, there is malrotation. Therefore, the procedure is known as Ladd's procedure. There are 5 main components of the Ladd procedure. Number 1, evisceration of the bowel and inspection of the mesenteric root. We will see the root of the mesentery, and we will see the bowel whether it is healthy or it has already have ischemia. Then counterclockwise derotation of the midgut volvulus. If there is midgut volvulus, then we counterclockwisely derotate the midgut volvulus. Then we have the lysis of the Ladd's band. If there is any kind of band present, we have to cut the Ladd's band so that we can freely straighten the duodenum and straighten the small intestine. Then we will do appendectomy. Appendectomy is also done in this, and placement of cecum in the lower quadrant. Cecum is if there is subhepatic cecum or subpyloric cecum, then cecum is pulled down and placed into the lower quadrant. So these are the 5 main components of the Ladd's procedure. Now what is the surgical outcome? In Ladd's procedure there might be, if suppose we have the bowel ischemia is present. But after we have done the Ladd's procedure, the bowel may become viable. Means first the bowel was brownish or blackish. After derotation, there is viable pink bowel is present and peristalsis is also present. Then we do not need to do any kind of resection. We will observe the bowel for 15 to 30 minutes. Then we will close the abdomen. Or there may be an ischemia present. Means one part of the bowel is still ischemic. Even after derotation, it is still ischemic. Then what we will do, we will cut this segment of the bowel and we anastomose normal segment with another normal segment if there is a small ischemia. And if we have a massive ischemia present, means a long segment of bowel is ischemic and they are blackish and there is no peristalsis, then we can have to do a second look for bowel viability. What is second look operation? In second look operation, the first we do the surgical exploration, we inspect the bowel, we do the resection anastomosis or we make a stoma, and we generally do not close the skin. We generally do the facial closure, or there we leave the abdomen open and we can place a silo bag. And after 1 week, when patient is stabilized, we will see the bowel again, whether the bowel is ischemic or normal. If it is ischemic, then we have to further do the resection and anastomosis. If it is not ischemic and good, then we will close the abdomen. This is massive. In cases of massive ischemia, we do second look operation. And what are the complications of Ladd's procedure? There might be wound infection. There might be short bowel syndrome. In my further classes, I will tell you about the short bowel syndrome. And they can have prolonged ileus, recurrent volvulus. Again, volvulus may happen. And there is post-operative intussusception, which is seen in 3% of cases. That is post-operative intussusception. Thank you for watching this video, guys. Please do like, share and subscribe to my channel so that I can make more free videos for you guys. Thank you.